Afternoon. Thank you for joining the noon session of our World AIDS Day virtual conference. Today's session is entitled Keeping It 100, Facts, Fictions, and the Real Deal on HIV. I am Ashley Anderson from the Atlanta Suburban Alumni Chapter of Delta Sigma Theta Sorority Incorporated. The Atlanta Suburban Chapter collaborated with Empowerment Resource Center to bring you this virtual World AIDS Day conference. We celebrate and spotlight World AIDS Day to encourage everyone to know their status and to celebrate the HIV heroes in the community. Our moderator today is Atlanta's own Jennifer Bellamy from 11 Alive News. Jennifer is a graduate of the University of Georgia, go Dogs, and a member of Delta Sigma Theta Sorority Incorporated. Jennifer joined the 11 Alive team in April 2015. She enjoys Bulldog and Falcons football, music, traveling, and spending time with her family and friends. Today's panelists are members of the ERC medical team. We have Dr. Zahid Afridi, Lauren Allain, Season Barnette, T. Brumfield, and Antonina Foster. This session is about debunking myths regarding HIV and AIDS. So if you have any questions, comments, concerns, put those in the chat, the Facebook chat, or the Zoom Facebook comment or Zoom chat, and we'll get those to Jennifer so she can ask the panel. Once again, thank you for joining us. We hope you learn lots, know your status, and Jennifer, you have the floor.
All right, thank you so much, and good afternoon to everyone. Thank you so much for being with us, and thank you for inviting me to participate. This is such an important topic and something that deserves our attention today, so thank you to you guys for putting this on, and thank you to our panelists for being a part of it. I know our panelists have worked on a presentation that we're going to get to in just a few moments, but we do want to kind of break the ice a little bit, if you will, and start off with a few questions just to kind of get everybody settled and going here. So I'm going to start with you, Dr. Afridi, and ask you, what do you think are some of the biggest myths and misconceptions when it comes to HIV and AIDS?
I think perhaps the biggest one that I see is that this is a gay man's disease. And yes, about 75% of new HIV infections in 2018 were among men. 1/4, 25%, were women. And so that is a myth that I would like to debunk, because everybody needs to get tested regardless of gender. Yeah, I think that's the biggest one.
Lauren, talk to me a little bit about what motivates you to do this work and get this message out to our community.
I came from internal medicine, and to me, working with this special population has been especially rewarding, because I'm also a member of the queer community, and I really enjoyed in my time in internal medicine working with this patient population. So I'm thrilled to be able to have the opportunity to, again, spend most of my time working with PrEP, PEP, and STI treatment, and participate in education as well. So far, being here has been a wonderful experience.
Susan, same question for you. What motivates you to get out here and do this work and help our communities when it comes to HIV and AIDS?
Well, hi, everybody. I started off working with the LGBTQ community, doing PEP, and for me, what motivates me is normalizing testing, making sure that people understand that anyone should get tested, and they should get tested consistently, knowing their status and knowing the options available to them if they want to prevent HIV, and if they do contract it, that it's not a death sentence. You can live a long, healthy, beautiful life, get married, have children. You can do all of that, but you have to normalize getting tested and knowing your status across the board, not just with HIV, but STIs as well. So that's what motivates me, is informing people.
T, now to you, what do you think people should know about HIV and AIDS that people maybe don't know? There's a lot of confusion. We talked about some of the misconceptions. What do you think people should know?
Really, that HIV is, although we are hopeful that there's going to be a cure, it is something that is very real, something that we still do need to be speaking about heavily. We need to break down the stigmas around it so that people who do have HIV feel more comfortable to disclose themselves, to take better care of themselves, to encourage those around them to also be doing the same, and to prevent this from happening, because it is something that is preventable. So I just want people to know that this is something that we definitely should be discussing more
Anthony,
often.
thank you, T. And Anthony, same question for you. What do you think people should know about HIV and AIDS?
Oh, she's muted. Sorry.
Oh, thank you. As Susan just mentioned, I think it's really important, particularly within the populations that I work with which are primarily African-American females, that testing, one, should be normalized. And on top of that, if someone does test positive, again, eliminated the stigma, because that's one of the largest issues that I see when speaking with my patients, not only at ERC, but also here at Emory University. Stigma prevents not only treatment, but prevents disclosure, because disclosure is a huge issue also. So I think, again, just debunking that risk, that also normalizing and also eliminating the stigma are very important.
All right, a lot of good information already going there. So thank you guys. I'm going to turn it over now to you to present your presentation.
Very good. Thank you everyone for joining us and for giving us the opportunity to talk about this very important topic. As you see, there's 5 of us here today. Before we talk about HIV in itself, I wanted to mention a little bit about what Empowerment Resource Center is and what we do. So we are an organization that has been around since 2003. We are a nonprofit, and we have different ways that we approach HIV. We have an outreach team that goes out into the community and offers testing. And then we have the clinic, which we call the CIC, Comprehensive Intervention Clinic, which is getting busier as we grow. And as you can see, we had over 4,000 unique clients that we served in 2019, last year. Here's the mission. Essentially, it's to provide services, programs, solutions for the health-related quality of life for the communities. And our vision is to achieve better health outcomes, and that's across not just HIV, but as you'll see farther down the slides, also sexually transmitted infections and behavioral health, and a few other fields that we're branching out into, but more on that in the future. So like I said, we have different teams. Clinical services and health literacy programs, I guess, kind of to some extent go hand in hand, because in the clinic we also have a heavy emphasis on health literacy. But that's not just limited to the clinic itself, also outside of it. We have a behavioral health services program, and of course, capacity building and partnerships for research. History. We are a fairly young organization in the HIV world, but we have been making significant and steady progress over the years. From 2010, when we saw our first self-pay client, to 2015, when we started offering PrEP and PEP. PrEP is, for those of you that may not know, a pre-exposure prophylaxis for HIV, meaning medicine that you take before being exposed to HIV to prevent acquiring it or to significantly reduce your chances of acquiring it. And PEP is post-exposure prophylaxis, meaning medication you take after being exposed to HIV to significantly reduce your chances of infections. 2016, medical provider. 2017, we moved to our current location. The next year, we added PrEP satellite locations. Last year, we added Greenway, which is an EMR that we use. And in 2020, we had telehealth virtual services, but with COVID, that part has grown significantly out of necessity. A bit of a busy slide. I'm not going to go through all of it, but it gives you an idea of what we do. We do provide free and low-cost services for STI treatment and testing, immunizations, as well as family planning services. Health literacy programs, as some of the speakers alluded to earlier, stigma is a big barrier when it comes to HIV. And so health literacy programs focus not only on kind of breaking down that stigma, but also STIs, safe sex practices, the nature of the condition, the treatment, prognosis. We have trained health service coordinators. T on our panel is one of our great health service coordinators, and then the outreach team that does testing also offers education. Behavioral health services, again, a department that we're growing. We have substance abuse, outpatient treatment program, as well as therapy, counseling, psychotropic medications, case management services, and drug screening because of the substance abuse program. So now to the meat and potatoes of what we are talking about today, which is HIV and PrEP usage. So as I mentioned briefly earlier, PrEP, which is pre-exposure prophylaxis, is a pill that you take every day that contains two medications, tenofovir and emtricitabine. The trade name, there are two different medications that are approved for PrEP. Both are a pill a day. The common trade name that you may or may not have heard is Truvada is the one that came out first, and Descovy is the newer one. They are very, very similar with just a little improved side effect profile with Descovy. So these medications, they reduce your chances of getting an infection for HIV from sex or injection drug use. The most common cause of failure of PrEP is poor adherence to the regimen, meaning if you do not take it daily as instructed, then the levels of medication in your system fall to the point where they may not be protective. How effective is it? If taken properly, 99% for sexual transmission. And in IV drug users, it has not been very well studied, but the numbers we do have suggest about a 74-75% effectiveness. And it is thought that this might be related to not taking the medication as you're supposed to take it. The CDC recommendation for who should use PrEP is individuals who have had anal or vaginal sex and in the past 6 months and have a partner with HIV who are not consistently using a condom or who have been diagnosed with an STI in the past 6 months. Injection drug users, if they share needles or if they have a partner with HIV, then PrEP is a good idea. Here I'm going to hand off to Lauren.
Thank you, Dr. Afridi. So I'm going to talk briefly about HIV infections in the United States. This data is from 2018. And as you can see, the vast majority of infections of HIV are occurring in Black/African-American male to male, basically men who have sex with men. And a second to that would be Hispanic, Latino male to male, and white male to male. You go down further and you see that Black African-American men who are having heterosexual sex is a much smaller number. However, this is not something to ignore. And I want to speak a little bit about women in PrEP. And I think that there's a lot of misinformation on women in PrEP. Women a lot of times don't think it applies to them. As Dr. Afridi mentioned earlier, a lot of the cultural perception is this is a gay man's disease, but PrEP is extremely effective in preventing HIV in HIV negative women. We see an extremely disproportionately high infection rate of HIV, especially in Black women. So 1 in 54 Black women compared to 1 in 256 Hispanic women and 1 in 941 white women are infected with HIV every year. And this data is from the CDC. So if we can break down some of these barriers and educate our female patients, and these are women who are having sex with men or who are bisexual, these women are at risk for HIV. We need to test them as frequently as we do our male patients and break down some of the cultural barriers around women in PrEP. And especially as providers, we need to identify our own biases in terms of who qualifies for PrEP, who is it appropriate for? And the answer is just about everybody. I think another bias or another barrier to care is the cost, but there are programs for people who meet the income levels that do cover PrEP and PEP for free if patients meet those criteria. So there's really no reason we shouldn't be educating our heterosexual women about this treatment.
T?
So just to add to that, these are more of the statistics that you'll see. It really breaks it down for you. So you'll see that in African-American men who sleep with men, it's 1 in 2 people. That's literally if this Zoom meeting had 300 people, that means, and they were all men who sleep with men, that means half of them would have HIV. And so the fact, this question to me is not a question that I like or understand that much, because I don't understand why we're still questioning why PrEP is important, given the statistics that we see every day. It's still becoming a rising thing, and it's a way to protect yourself. You now have a tool. Everyone has a tool to put on their safety belt to protect them from something that is as life-altering as HIV is. So it really is, it's the question of its importance really is not valid to me, because we all know that it's important. And this is something that we definitely should all be looking into. And like Lauren was saying, there's barriers and things that we just need to get past and inform people that this is definitely something attainable to everyone. And so now we'll go over to Season on how we can get on PrEP.
So how do you get on PrEP? Of course, ERC does provide PrEP at no cost. You can call us to make an appointment. We also have a confidential online contact form. in which we would reach out to you and answer any questions and set up an appointment. There are also apps that you can use to get your hands on PrEP, such as Mister. Your primary care provider can help you get on PrEP. Also, there is a website where you can search to find locations close to you that will help you get on PrEP. www.preplocator.org. And that will be a good tool for you to use to find somewhere to get on PrEP.
All right, that looks like the end of our presentation. I do want to go ahead and remind everyone that is joining us via Facebook or the Zoom that the chat and comment sections are available, so you can ask any questions that maybe came up during the presentation or anything that you maybe have been wondering. Just go ahead and drop those questions in our chat and in the comment sections, and we'll work to get you some of that information, get you the answers from the experts that we have on our panel today. I kind of want to go back to Dr. Afridi. You mentioned during part of the your presentation that PrEP has an effectiveness of 99%. A lot of folks might be wondering, why not 100%?
Good question. There have in the literature been 2 cases recorded where HIV transmission did occur in spite of proper adherence with the PrEP regimen. And this is, of course, across millions of people around the world that are on PrEP. And what had happened was the HIV virus can develop mutations that offer some degree of resistance to medications. In these 2 cases, what had happened was that the virus from the partner who had HIV had 4 mutations, which is exceedingly rare. But it had 4 mutations that provided it resistance to both medications in PrEP. And so, you know, we wish it was 100%, but it is not. And so that makes it all the more important to use condoms. PrEP is not a substitute for condom use. It does not protect against any other sexually transmitted infection. And so just being on PrEP does not mean that conventional safe-sex practices are out the window. They should still be adhered to.
All right, Dr. Afridi, thank you. We do have some questions coming in, and whoever thinks they're best equipped to answer, feel free to jump in and give us that information. One question is, do Black women who are, well, I'll come back to that one, that's still being processed. When we look at the increases of HIV in our community, how is the usage and acceptance of PrEP in those areas, and what advice do you have to increase awareness and acceptance in those communities?
Antonina, that might be a good one for you.
I know I was sitting here thinking on it as she was saying the question. Again, it all goes back to normalizing HIV. I mean, I think take for example, someone with diabetes or hypertension. I'm not making these comparisons. I'm just going to look at it as a chronic condition. So if HIV was viewed the same way as diabetes or as hypertension, which now, in all honesty, I think Susan alluded to this when she talked about treatment, HIV is truly a chronic condition now. If a person takes treatment, if they are adherent to their medication, it is chronic. They can live full, productive lives, as she mentioned earlier. So if we normalize it in that sense, saying that, okay, you look at HIV in the same sense, then PrEP, testing, treatment, all of that will be viewed in a similar sense. And these are all issues that unfortunately affect in a higher rate the African-American community. So if you say, okay, I'm going to be tested for diabetes, I'm going to be tested for HIV, I'm going to take something to prevent me from developing, I'm going to do something to prevent developing diabetes, I'm going to do something to prevent myself or my friends or my family or whomever, my partner from contracting HIV. I think if we looked at it in that sense, it would be a lot, the acceptance rate will be higher, again, particularly amongst African-American women. I think we've gotten a higher acceptance rate is from just my own kind of observation amongst African-American men, but we haven't gotten that same acceptance amongst African-American women.
Anybody else want to chime in on that?
Yes, I'll just quickly say that anybody out there that's wondering, why hasn't my doctor or provider mentioned this to me? That there could be a lot of reasons. We talked about barriers earlier, and a lot of that falls on the provider themselves for not bringing it up. So as a patient, take your life into your own hands and take your health into your own hands. Go to your provider and say, I want to know about this. I want to be tested for HIV. Please tell me more about PrEP. And if you don't know, I would love to be referred to a resource where I can find out more information. So be your own advocate and get to your doctor and find out as much as you can from that person.
Got it. We've seen a lot of advancements in the medical field when it comes to HIV/AIDS. In fact, last year I did a story with a young lady here in Atlanta who was one of the first HIV to HIV living transplant donors in the United States. So we're seeing a lot of advancements. What do y'all see on the horizon that could be a big change in HIV and what we're seeing?
I'll take that one. So the thing that I'm excited about is long-acting injectable medications. There are a couple of regimens that are being studied, not only as treatment for HIV, but also for PrEP. And I believe they're being studied at 1 dose a month or 1 dose every other month. It's an intramuscular injection. And the reason that I'm excited about that is, you know, earlier on when I said you have to, you'll get 99% protection with proper adherence to taking a pill a day. With the injection, you don't have to worry about taking the pill every day. People forget, people go out of town, didn't bring their pills with them, you know, life happens. But with the injection, probably, I think the every other month regimen is what's going to be approved. Now, when I say probably, I don't know for sure, but that's, I think, where things are going to go. It becomes so convenient, you know, whether we're talking about treatment or PrEP. Go to your doctor's office, get the shot, you're good for 2 months. So that's one thing that I personally am excited about, because adherence to the regimen, the pill a day, is not easy. And is the reason for so many failures with PrEP and with treatment. The one thing that often is brought up is cure. How far away are we from a cure? And unfortunately, there isn't anything on the horizon, at least in the short term, that may suggest that we may be able to develop a cure. So I guess that doesn't answer your question because you're talking about what may be exciting. But I know people always ask this question, so might as well get it out there.
Yeah. Anybody else have anything that they're looking forward to that they think is on the horizon that'll make an impact?
Yeah, I think I find excitement in the smaller victories. We have patients who are bringing in their friends 2 and 3 at a time to get tested, to initiate PrEP, holding each other's hands. I think the word of mouth is starting to grow. I have several patients who are just downright advocates for PrEP. They are activists, they're guest speakers, they do so much work in the community, and there are patients at ERC. So that's what really gets me excited about PrEP and PEP, is that our patients, or a lot of the patients that I see, they're not just worried about them. they're concerned about their friends. They want to spread the word. They want to put the information out there. So I think that's what, on the day-to-day basis, what I see and I get excited about.
Awesome. T, did you have something to say?
Yeah, and then I'm really excited for a time when I know, like Lauren was mentioning before, it's not really something that our primary care doctors are readily just offering to us or speaking to us about. So I really do hope and look forward to a time when that is more the standard for anyone when they go to the doctor, just at the age where you can start being sexually active. It would be nice if we just get that offer. Do you want to start PrEP? Have you heard about PrEP? Do you know all about HIV? I look forward to a time when it's just out in the forefront.
Got it. I do want to get another question that we have from someone who is attending the panel today. This one I kind of started before. It says, do the Black women that you mentioned in the presentation who are infected with HIV fit the profile of those who you suggested take PrEP? For instance, heterosexual women who are in what they believe to be a monogamous relationship, do they fit the criteria for PrEP?
So I'll take this. I think you mentioned HIV positive women in the
Yes.
question. So anybody who's HIV positive would not be a candidate for PrEP. So
Okay.
they would be on antiretroviral therapy for HIV. So PrEP is for women or men who are at risk for HIV, but are HIV negative. So that's the first part. So the second part of the question was concerning, I'm sorry, can you?
It was just giving an example, but I think you kind of answered that when you said that it would be for that person's partner. Would that be accurate to say it would be for that?
Yeah, yeah, exactly. Oh yeah, both. I mean, monogamous relationships are only monogamous if each partner is 100% true to the other partner. That's not always the standard. So yeah, absolutely. Both people in the relationship would benefit from being on PrEP if they're in a monogamous relationship, because you never know. As somebody mentioned earlier, life happens, people make mistakes. And if you feel like that's even a possibility, PrEP can be something that is extremely helpful and protective.
And just to add to that, the people that I see coming in that are on PrEP and everything, because I see them every day, they look just like the women that are in this room right now. They're my mother, they're my sister, they're my aunt, they're my cousin. It literally affects everyone. To just make it real to everyone, it's not a certain lifestyle. It's not because somebody is more sexually active. It's not to sound so cruel, but the hands that we get dealt in life, anybody can benefit from this because we never know.
Yeah. I want to move back to talking about PrEP. Are there any side effects that people should be concerned about when they're, starting a new treatment? That's something we should always be, looking into, whatever the treatment. So what can y'all tell us about that in terms of people who are considering PrEP or looking at that as an option?
Hazel?
Sure. So some of the common side effects that our patients report are pretty much upset stomachs, some nausea, occasionally some vomiting. They might experience some mild diarrhea. We have heard a few reported cases of abnormal dreams or an occasional headache, but most of our patients report that it goes, within around 7 to 10 days, it gets better and is typically gone by the second week that you're on the medication. We do definitely teach our patients to look out for any adverse reactions or any allergic reactions to the medications. Those are typically rare, but our most common side effects are your upset stomach, some nausea, occasional vomiting, and some mild diarrhea.
Okay. I do want to kind of go back to something that I believe y'all mentioned during the presentation, but I think it's important to talk about it again, because sometimes you hear about treatments and you figure that it's not accessible to you, that I can't get this, it's too expensive, my company might not cover it on insurance. What should people know about gaining access and, like you mentioned, becoming their own advocate?
literally anyone that wants PrEP can get PrEP. If you make too much and you feel like you still don't make enough to cover your needs and get this medication, you would speak to somebody like me. There's a lot of programs that are through the manufacturer of the drug that allow so many people to get this drug, if not at a discounted rate, for free. And it'll cover your doctor's visits, it'll cover your labs, and it'll even cover everything with the pharmacy. So there is always a way to get PrEP. Reach out to, for any drug, reach out to the manufacturer to see if there's any assistance. But then you always have people like us and on our team that will make sure that we get this to you.
I know we talked about some of the information with the slide, that information from the CDC. We do have someone who was wondering if there's been any updated information since 2018, but we know sometimes there can be a lag in compiling the data and getting it actually out there to people. But what do we know about that process in terms of collecting this data and getting the information out to organizations like yours and others to help grow awareness and knowledge?
Antonina, you want to take that one?
I was just thinking, it's Jennifer, consistently, and I've gone to many international conferences when we talk about the data lag, especially in the United States as an industrialized country, because in comparison with other, even some second world countries, we do have somewhat of a data lag. So that 2018 data is going to be pretty much as up to date as you're going to get for your national data. Some states, and I can't really say off the top of my head if Georgia is one of those states that may do a little bit better in maybe at least the data being maybe just a year behind, but some state by state data is a little bit better. But again, on the national level, it's going to still be, that's going to be your most up-to-date data.
Okay. And I know we, when we were looking at that data, we were looking at the breakdowns there in terms of race and sexual partners. So why do we see new infections among minorities most, specifically Black and Latinos? Why is that? Is that kind of something that goes along with what we see for other health issues and concerns, that there's misconceptions, that there are a lack of access to care? What are we kind of seeing that causes that?
Well, we have social determinants just amongst our race. We don't always encourage each other to seek out healthcare. And sometimes we try to handle matters personally, when if we just share with everyone, we might get the resources that we actually need. So that's something that I see when I'm speaking to clients.
He answered that pretty much. He answered that appropriately, saying it's really the social determinants of health. You answered it yourself, Jennifer, by saying in many instances it's a lack of access. And just as T mentioned, I mean, a lot of times people do not know that there are agencies such as ERC that will offer these resources for either for free or very reduced prices. So it's again, just the lack of access, the lack of knowledge of access. So that goes along with some health literacy issues and not being able to, just not knowing how to kind of put your feelers out there and see what's available, because you just don't know. Because you can't, if you don't know, you don't know, unfortunately. So I think it's just going to really come again. I mean, it's a continuous soapbox, but if we normalize these things, if we continue to have educational sessions such as this one, or we make it more widely available, because unfortunately, I think a lot of people that may be on this session are people that may already be in the know. So if we can really make sure that we're getting the message out there to men and women who just do not have they just don't have the access, they just really do not know.
And let me just add to that your first stop, your primary care providers are not providing the information. They're making assumptions based on race, social class, and sexual behavior that could possibly determine whether a patient learns about PrEP or has access to PrEP.
Speaking of PrEP, is there a specific age group that could benefit most from PrEP?
So if you look at the data, the highest number of new infections is in the 18 to 29 age group. I've seen it where, so I don't know if the participants are aware, but Georgia is #1 for new HIV infections in the country. That is not a number that we like. We'd rather be 50th than #1. And of course, most of those are occurring in the Atlanta metro area. You know, young men, in my personal experience, I'm not quoting a study, but in my personal experience, I've often seen men who moved to the big city from a small town in Alabama or Mississippi, and you know, they're 19, 20 young men. They've been in an environment where they've either been closeted or have not had a very active sex life, and then you know, here comes this huge city with many opportunities. They go about being sexually active without proper protection. And next thing you know, HIV has reared its ugly head. So I think that's a long, convoluted way of saying the young ones, young adults.
Dr. Afridi, I think you addressed this, but I'm going to go ahead and ask, because we did get this in from one of our attendees about hearing that there's an injection soon for PrEP that will be longer lasting than the pill. So if you could again tell us what you know about the
Sure.
effectiveness of it and when we could see something like that available.
So I don't know for sure, but I have heard that it should be approved and available sometime in the late 3rd or 4th quarter of next year. For prevention, I believe the initial data has shown that it is, the word they use is non-inferior, which in layman's terms is it's pretty much equally as good as oral PrEP, the pill. So unless something changes, hopefully by this time next year, we'll be administering PrEP shots.
Great. Now, I know we are heading towards the end of our session here, but I do want to remind you, if you have any questions, you can still go ahead and put them in the chat or comment section of the Zoom and Facebook, and we'll try to get them answered for you. But I do kind of want to go back to one of the questions I kicked things off with, and Dr. Afridi was the only one I asked her, or one of the only ones that I asked this, but we were talking about busting myths. So what do the rest of you guys think are some things that people really just don't know about HIV/AIDS, maybe about PrEP? Just some misconceptions that you would like folks to know this is not right and this is the real deal.
I think there's still, and this is just even speaking with some of my patients that I see not only at ERC, again with Emory, that tell me, particularly my women who are living with HIV, they still have family members that have misconceptions about the way HIV is transmitted. I mean, you would think, I mean, are we 40 years in at this point? And we over that time, we know so much about the way HIV is transmitted that there's still individuals who think that, you know, they cannot eat after someone who's living with HIV or can't share bathroom facilities. These all sound like, oh no, this still can't be going on. But unfortunately, I definitely hear it from a lot of my patients. And that's, again, comes back with them not wanting to disclose because, you know, they feel that they will be stigmatized and be ostracized by their own family.
If I might add, there are assumptions about transmitting HIV, not just through casual contact, but in relationships. And if a person is HIV positive and they're on the appropriate therapy, the vast majority of the time, their viral load is undetectable. And if their viral load is undetectable, that HIV is not transmittable. So undetectable equals untransmittable. So you can have a normal relationship with a partner who's HIV positive as long as their viral load is undetectable, and the other person can be on PrEP just as an added protection. So you can have a normal sexual relationship with your partner who's HIV positive as long as they're undetectable. So that's something that has really been a revolution in HIV treatment, that these viral loads are, usually not detectable on appropriate treatment.
Anybody else want to add something, T?
Another one is, I don't know, not necessarily a myth, but just, I guess kind of that people can tell just by how someone looks that they have HIV. That is definitely not true at all. Studies have actually started showing that people with HIV that are taking care of themselves and living the healthiest life that they could can actually live longer than people with other health issues. So that just leads on to the next one, that you can also have HIV and not know it. So please don't think just, I don't have any symptoms, I haven't had any symptoms, blah, anything like that, so I don't need to go get a test. That's not the case. The CDC, along with everyone else, still recommends testing, especially if you are sexually active, every 3 months. If you are less sexually active, you can push that envelope to 6 months, but please stay within that 3 to 6 months because HIV does not have a face, and it is not always something that you know that you have.
And I would just add on top of all of that is, I think, especially when I'm dealing with my heterosexual patients, they kind of forget that intravenous drug use is a major risk factor. And, it's not just transmitted from male to male sex. If you have a partner who has a history of drug use or is currently using drugs, they have a major risk factor and they could contract it and transmit it to you too. So I'll get patients who are like, no, I know my man doesn't sleep with other men and I don't think, but it's like, well, does he use drugs? Do you know if he uses drugs? So it is just a stigma, and but I think that is something that gets overlooked quite a bit in certain groups of people. And like T said, you can't tell just by looking at somebody. I've had geriatric patients dying from cancer who've been HIV positive since the 60s. So they're living very long lives, and you don't know just by looking at someone. So I think those are definitely major myths or misconceptions.
All right, I know we're heading towards the end here, but I do want to go through and ask everyone on the panel to give us their thoughts on this. What do you think we can all be doing to work to break down the stigmas, the barriers, and misconceptions that there are surrounding HIV/AIDS?
I can address, I'll go first. I think talking about it. I've had patients who are HIV positive who live with mom and mom doesn't know. They will be talking to me about how to hide their pills, or I don't want to go to the pharmacy. Can they mail it to me in an unmarked box? Yes, we can do all of that. But some members of the community have to be courageous. I know this is easy for me to say, and it's hard for the person to do, but we like I think everybody has been saying, we need to normalize HIV. Do not consider yourself an outcast or a burden or somebody who's going to be stigmatized. Some people's reactions will not be favorable, but the more of us that take a stand and treat it as just any other chronic condition, the more of us that do that, the easier it will be for everybody else.
think just again, echoing Dr. Afridi, again, it's going to go back into normalizing it. Having these conversations, continuing to have not just on World AIDS Day, but continuing to have these conversations in a public setting, and really emphasizing that yes, you know, HIV is still out there. We have not gotten to the point where we haven't gotten to a cure yet. But if we can continue to have these conversations about treatment and prevention, we will get to that point where we will see our rate of new infections go down significantly, because just as Lauren said, if someone's on treatment, U equals U. If we are really talking about and really emphasizing the importance of PrEP, then we have, again, a highly effective preventive tool out there. But if we're not having these conversations, if we're not normalizing HIV and, you know, decreasing that stigma that's associated with HIV, then unfortunately we're not going to make the continued bounds or advancements that we need to, because we have the tools. But if we're not able to have individuals utilize those tools, then it's not going to be, you know, it's still going to be useless.
I think for me, of course, attacking those stigmas and normalizing things. But I think for me, being patient and being consistent. We give people information all day, every day, and they're still not ready. So we just have to be consistent in our message, and we have to be patient. We got to meet people where they're at, and we have to we just have to make sure we're staying on top of educating people. And when they're ready, they're ready. You know, not everybody is going to sign up to take a pill every day, and not everybody is going to believe us when we say you can get this for free. So that's a major key to getting through to people, is being consistent in your message and meeting them where they're at, and letting them know whenever you're ready, we're here for you. We got that PrEP for you. We got that PEP for you.
And I'll just say again, from my background in primary care, I encourage patients to talk to their providers. If their providers are not bringing it up, then you bringing it up. And from a provider standpoint, anybody that's out there that's listening, please make it as standard as a diabetes, hypertension, depression screen when you're seeing your patients. And for those people out there that don't have access to primary care, there are many, many community resources, including organizations like ERC. There's the health department. There are a variety of nonprofit clinics that are available with just a little bit of searching, and can be often accessed through, you know, just contact the health department. So there are ways to get to the information. So both as clinicians and patients, we just have to say, hey, please tell me about this. I want to know more. I want this to be part of my regular care, HIV screening and discussion.
And then we will talk about this until we are blue in the face. But sometimes for people, it really takes a more personal interaction for it to really hit home. So really, all of us in this room today, if we could just go and talk to 3 people that we know and ask them when the last time they got tested, what were they tested for, and maybe even throw in there, do you want to go get tested together, or let's plan to get tested? That conversation too, I think that's the first step that needs to start happening more often. And if we all just have that with 3 of our closest friends, and then they have it with 3 of their closest friends, we already starting a fire.
Great. Thank you all so much. I do want to have someone just kind of give the information for how people can get in touch with the ERC for themselves, or sharing with others too, before we wrap.
Is it possible to pull up the last slide from the presentation? There you go. Maybe we should leave that up for a while.
Great, thank you. I just wanted to make sure that everybody had the information to get in touch with all of you and to share this other information that they can with others as well. So thank you all.
Thank you.
Thank you, Jennifer.
Thank you all for joining our Keep It 100 session today at noon. Come back today at 7 p.m. Eastern Standard Time for Let's Rock the Ribbons together as we celebrate and highlight and spotlight HIV heroes in the community. Thank you and have a wonderful afternoon.
Thank you all.
Thank you, team. That was great. Thank you, everyone.